We have no idea what to do with a patient if they've gotten preoperative chemotherapy, radiation, surgery, now no evidence of disease. We have no idea what to do with that patient. We do know that that patient has a pretty high probability of relapse. Probably not cured. Might be, but probably not. So we want to give more chemo. Now let's say we have the patient who got FOLFIRINOX preoperatively, then chemoradiation. Well, we know that one of the best drugs adjuvantly is gemcitabine. So should we now give a little adjuvant gemcitabine? My bias would be yes, we should. And in fact, capecitabine is the standard doublet that one uses post-op. And even though they've already gotten fluoropyrimidine pre-op, I probably would give them a little more adjuvant therapy post-op based on no data, only risk and concern, if you will. But we don't know what to do. So I think an appropriate thing could be stop and observe. An appropriate step could be gem with some capecitabine if you haven't given it already. What if you gave gem nab-paclitaxel preoperatively? Well, that's a different story now, and particularly if you gave a little capecitabine during your radiation, you've kind of given those drugs. Should you give some more afterwards? I would still probably say yes. If the patient was doing okay, if their overall performance status was good, post-op, and they were doing okay, scans were negative, I probably would tack on a little more adjuvant therapy afterwards. Taking care of a patient with pancreas cancer is both a joy and a challenge. It takes a lot. It takes really people on the home front, so it's really nice if there's a significant other, or it's always the daughter, it's never the son, who is there to help support the patient. You need that. On our side, we need a lot too. Not only do we need the doc who's kind of driving, but you need all the nursing crew, the infusion suite, palliative care, nutrition is a big deal here, because these people are sick. They very often have pain and no appetite, losing weight. Where these tumors are often difficult around digestion. They have malabsorption. They often have biliary stents. So they're tricky to take care of. And you really need some experience and understanding of the mechanisms of all of that problem to support a patient. So it takes a village, both on the patient side and on our side, to manage that patient best. Our case, 64-year-old woman, gets preoperative chemo for her locally advanced pancreas cancer, is one of the lucky ones, has a nice response. Consolidate that with a little chemoradiation, surgery, comes back now, no evidence of disease, maybe cured, but probably not, considering further adjuvant therapy. If we think back on the years before when this was an incurable, we're just going to give this patient chemotherapy kind of approach, this is nice progress. We, of course, are frustrated. We want more with pancreas cancer. We want more medicines. We want better outcomes. We want earlier detection if we could get it. But to go from where we were to where we are, I think, is true progress.